Well, firstly, I'd like to thank Jim for setting this up so brilliantly in terms of providing the background. I'm enormously proud to have the opportunity to present for the first time the preliminary data from the International Collaborative Project to evaluate the availability and accessibility of opioids in Africa, Asia, Latin America, and the Caribbean, and the Middle East. Jim has already laid out the issues of what I call the opioid regulatory paradox, that there's a conflicting need to ensure that opioids are available for treating pain and also to prevent drugs from becoming a source of harm or abuse. As Jim pointed out, we have looked at this previously, the issues of opioid availability and accessibility in Europe, finding very substantial discrepancies in both formulary availability and the sorts of regulatory barriers, particularly between Western Europe and Eastern Europe. We knew that the situation was fairly well documented in the United States, Australia, and New Zealand, but for the rest of the world, there was sporadic reporting with inconsistent methodologies, and although we knew the picture was bad, there was a lack of a clear picture, and this is really what mandated us or compelled us to take on this task. So the areas that we're going to be looking at are Africa, and this is the slide that you've previously seen on the level of palliative care development, Asia, Central America, South America, and the Caribbean, and the Middle East. The aim of the study, the two aims, were to evaluate the formulary availability and cost to the consumer of a range of opioid drugs in the management of cancer pain, and also to evaluate the barriers to accessibility of the opioid drugs for patients with cancer pain in each of the participating countries. This has been a collaborative effort with coordinating partners, including the European Society of Medical Oncology, and particularly the Pain and Palliative Care Working Group, along with the Developing Countries Task Force, the European Association for Palliative Care, the Pain and Policy Study Group of the University of Wisconsin, the UICC, and importantly, as a partner for the first time, the WHO. The roles of the coordinating partners were in survey design, dissemination and data collection, data analysis, and will also have an ongoing role in authorship publication and post-publication policy initiatives. But we've also had another 17 collaborating partners from palliative care and oncology organisations around the world. And they've had key roles, particularly in identifying potential credentialed reporters and also with authorship and post-publication policy initiatives. The survey that we used was based on the tool that we developed in the previous study. There are a couple of modifications introducing some subjective elements which I will highlight with the presentation of the data. The survey was prepared in English, French and Spanish versions. Data reporters, these are the term that we've used are field reporters, and these are known, credible professionals nominated by the collaborating and coordinating partners in each of the countries. And we sent out invitations to at least 2 reporters in each country. The data was collected electronically. It was cross-checked when we had multiple reporters and clarifications of discrepancies between reporters. Where there was conflicting data, we sought clarifications. Priority was given to very highly credentialed reporters, and what you'll be seeing is representative data. I'm going to present 10 elements in the results: the response rate, the formulary and cost for the 7 essential opioid medications, data on the actual availability, or reports on the actual availability of the 7 essential opioids, and then a range of different restrictions, including the need for patient permits, restrictions on prescribing authority, restrictions on the number of days that can be supplied on a single prescription, complex prescribing forms, restrictions on pharmacists, restrictions in dispensing, and then finally some comments about laws regarding the medical use of opioids. As you'll see, the response rate for the study Looking by the number of countries, we invited 161 countries and states. That's 28 Indian states. We have data on 93, which is an overall response rate of 57%. However, if you look at the populations of the countries that we've studied, we sent out invitations relevant to almost 6 billion people, and we have data back on relevant to almost 5 billion people, with an overall response rate by population of 83%. Just to remind you, these are the four opioid formulations in the WHO essential drug list, and these are the other 3 opioid formulations added by the International Association for Hospice and Palliative Care. For purposes of this study, we have not defined tramadol as an opioid. So, the first chart, and all of the charts you'll see are color-coded. The first chart looks at the formulary and costs of the 7 opioids. Just to look at the scale here, the light blue is free, green is less than 25% cost, the darker blue is 25 to 50% of the cost. Orange indicates there's a discount, but that discount is less than 50%. And red is the full price of the medication. And we're going to see this pattern for the next several slides. So this is the data for Latin America and the Caribbean. Looking in Africa, you see a lot more drugs where people needed to pay full cost and large areas with drugs missing. And I would like you to keep your focus on the issue that's been highlighted of oral immediate release morphine, and countries where even that is not available. The Middle East, the costs across Asia, again, similar patterns, but look at the cost in India, where there is, at least on a formulary basis, fairly wide availability, but patients who need these drugs need to pay full cost for them. We asked the reporters, if a patient has a valid prescription, how easy is it for them to actually get the medication? What's the actual availability on site? And we asked them to rank that as either always available, they can usually get it, they can get it half the time, they can get it occasionally, or they can never get it. Again, this is looking at the range of countries in Latin America and the Caribbean. Again, we're starting to see more red appearing in this data in Africa with a range of drugs which are relatively unavailable. Across the Middle East, a spattering of red, a spattering of drugs that are usually available. Some drugs, for instance, oral morphine in Egypt is available half the time, and we have a range of Middle Eastern countries where there's no available immediate release morphine. Asia, a similar pattern, and then look at India. Okay, that even if you have a valid prescription, you can only get that prescription filled occasionally. Eligibility restrictions refer to the requirement for the patient to have a permit in order to be able to receive an opioid prescription. And we asked if permits were required for outpatients, for inpatients, and for hospice patients. And you see here in both Africa and the Middle East, in many countries, permits are required in order to be able to be eligible to receive a prescription. We see the same pattern in really across all of the countries that we've studied, Latin and South America, Asia, and India. Okay. The third barrier that we've looked at is restrictions in prescribing authority. So you've already got now your permit, okay, but can your physician prescribe the opioids? And in fact, there are many countries in which physicians can only prescribe an opioid if they have a special permission, and sometimes certain sorts of doctors can only prescribe on an emergency situation. And we also asked about non-medical prescribing, particularly in a situation where there's not a doctor available. So we'll see in Africa, again, in most of the countries, the permits actually were not required. In some countries, family physicians or surgeons would require a special permit. And we see a smattering of countries that do allow nurse or pharmacist prescribing if there's no doctor available, which is encouraging. In the Middle East, again, we see more countries now requiring a permit, a special permit or license for physicians to prescribe opioids. Some sorts of doctors, family doctors in Iraq, Palestine, Qatar, and Yemen are not allowed to prescribe opioids. Latin America, a similar picture. We have, again, some non-physicians with prescribing privileges in a small smattering of countries. Asia, again, widespread requirements for special permits for prescribing. And in India, family doctors are extremely limited, and in many states either need permits or can only prescribe in an emergency situation. So if we've gotten past the first two stages and you get a prescription, for how many days is that prescription valid? And we got actual numbers, the number of days that the prescription is valid, and the color coding is red is less than a week. The pink is for 1 to 2 weeks, green is 2 to 4 weeks, and blue is 4 weeks or more. And so I'd like you to keep your eyes on the prevalence of red and pink in these slides. And we'll see here about a third of countries across Africa, and about half the countries in the Middle East are limited to less than a 1 week supply. In Latin America, the picture here is looks a little bit better. In Asia and the Indian states, this is not, for most of these places, this is not a major limitation. What are the bureaucratic burdens on physicians in writing a prescription? Do they need to write triplicate prescriptions? Do they need special forms? Do they need to pay for the forms? So here we've asked, do you need a duplicate or triplicate prescription? Do they need to be on a special form? Are the forms readily available? And if there are special forms, do you have to pay for them in order to get them? And what we see is all over that the requirement for either special forms or triplicate forms are a very, very widespread requirement in all of the countries that we looked at, in all of the regions that we looked at. Latin America and the Caribbean, Asia and the Indian states. What are the restrictions on the pharmacist? In an emergency situation, can a physician phone in or fax in an emergency prescription? Or if a patient comes along with a prescription that has a technical error in it, can the pharmacist correct the technical error, or do they need to send the patient back to the prescribing doctor? We see overall that very few countries will allow prescriptions either to be faxed or phoned in, and in most countries preclude a pharmacist correcting a technical error on a prescription. So if there's an error, you've got to go back to square one. This is true in Africa and the Middle East. This is true in Latin America and the Caribbean. This is true in Asia and India. Okay, dispensing restrictions. When you've got your prescription, where do you get it? Where do you get the prescription filled? Do you get it filled at any pharmacy? Only at a hospital pharmacy? At a single designated pharmacy for each patient? At some other specific designated location, and we had the example in Europe, in Georgia, that you'd get your prescription filled at the police station, or only at a pharmacy that accepts the patient's insurance. So that's the first column. The subjective question we asked the report is how accessible are these sites of dispensing to the patients? So they're usually accessible, always, usually, half the time, occasionally, or almost never. So what we see overall is we see that in many of the countries, that dispensing is actually limited to hospital pharmacies, but the site reporters are saying that the patients often can't get to them and can't get to the sites where the opioids are being dispensed. And we see this pattern really across all of the sites we've looked at: Africa, the Middle East, Latin America and the Caribbean, Asia, and the Indian states. Finally, we looked at the issue of negative laws regarding the medical use of opioids. And the two questions that we asked is, do the local laws regarding opioids use negative language such as poisons, drugs of addiction, or other pejorative terms? And we asked also, do the laws specifically preclude people who are taking opioids from being able to drive? Again, the results here are very variable. About half the states had used negative language in the laws, and an absolute prohibition on driving was fairly prevalent. Again, Africa and the Middle East, in the Latin America and the Caribbean, Asia. India has a single law regarding this issue, which does not use pejorative language. So, to pull all the data together, we have classified or stratified the formularies as either good, limited, very limited, or poor, based on the compliance with the WHO Essential Drug List and the the International Association for Hospice and Palliative Care Essential Drug List. And this is sort of an overall situation with about half the countries or more having either the limited or relatively limited and sometimes very, very limited formulary availability. And mapping this out across the world, the countries in blue had good formularies, the ones in green limited, and the red ones are the countries that have only really one or two of the essential drugs available. This is an overview of how many different sorts of restrictive regulations are different countries using. In blue are the countries that have got less than 3 restrictive domains. Countries with 4 to 5 are in purple, and countries with 6 or more out of the 8 different domains of restrictions are listed in red. And what we saw overall is that 70% I think about 70% of the world had 4 or more restrictions, and about 40% of the countries had 6 or more restrictions. So this is the spread for Africa, the Middle East, a lot of restrictions, Latin America and the Caribbean, and Asia, and the Indian states. So, and again, we can map that out, looking at the countries that have the highest level of restriction, the blue ones with the lowest levels of restriction, and the pink ones in between. So several disclaimers about the data. The data that we have about the regulations come from field reporters. They were asked, where possible, to verify the information with regulators, and some have done that, some have not. There is a plan to put the data up for open peer review, and that's going to happen over the next several months. And we did, sometimes we did have conflicting data. If we couldn't resolve it, we've gone by the most highly credentialed reporter that submitted data. So to conclude, in many places across Africa, Asia, the Middle East and Latin America, it is clear that governments are falling short. There's a huge need for affordable opioids for the management of cancer pain. In many places, the drugs, even the drugs that are on formulary, are not routinely and readily available. And we have data to show that overregulation is very widespread, with 84% of the surveyed countries having 4 or more different sorts of barriers, and 39% having 6 or more different barriers. This data, as well as the background information that we've heard from Jim, really is a call to action, and there's an urgent need for formulary review, for improving the affordability of medications, for improving availability with better distribution and dispensing, for a careful re-examination of multiple drug control policies, and for repeal of excessive restrictions which are impeding this most fundamental aspect of cancer care. This work is already being done. There are lots of people in the world that are doing it. Even just this morning, I've received further update about the involvement of the Supreme Court in India, pushing this agenda for regulatory reform and possibly taking the authority away from the states and centralising it with the central government. This has been, as you said, this is an enormous project. This could not have happened without the phenomenal logistic assistance I received from Grace Marie Bricali at ESMO, and from Heidi Blumhuber, Emilia Giordano, and Silvana Gori, all from the EAPC. We had 156 field reporters who have submitted data to us, and this has really been a phenomenal team effort between the 5 coordinating partners and the 17 collaborating partners. And this couldn't have happened without the investment, energy, and involvement of all of these people. So this is a baseline. This is working data for us, and now we have the task ahead of us of taking this out, taking this information out to use it as a tool to formulate an important changes in policy. Thank you very much.